Hello, I'm Dr. Ashley Ross, a urologist who specializes in prostate cancer. In this video, I want to review with you elements of the research use only Decipher GRID report. The Decipher GRID genomic database was first established in 2015. As you may be aware, when a Decipher test is performed, a whole transcriptome microarray is performed on the tumor sample. This means that there's an analysis of tens of thousands of genes from each patient's tumor. To date, there's over 140,000 prostate cancer transcriptomes stored in the GRID database. This makes the GRID the largest and most well-annotated urologic oncology gene expression database in the world. The GRID aggregates not only that gene expression data, but then analyzes over 400 gene signatures that were either developed through Veracyte Decipher's internal discovery process, fostered by collaboration with researchers in both academic and community settings, as well as research with cooperative groups, or it brings in models that were previously published in the literature that are then carefully incorporated into the GRID. In the new version of the Decipher GRID report, there's an attempt to collate all of this rich information and present it in a way that is digestible to us as researchers and clinician scientists. While the data is relatively complex, even when presented in this fashion, this video is an attempt for us to walk through the data page by page and discuss how we can understand the information contained in the GRID report. It's worth noting that there are some signatures on the report that have higher levels of validation than others. Some, for example, have been developed as part of analysis of very large phase 3 clinical trials, such as Stampede, Charted, and Titan, and others have been developed in other fashions using data from registries and other materials. So let's get going. And as we walk through this report, let's keep in mind that the GRID remains research use only. This is page 1 of the Decipher GRID report. First, we will see on the left-hand corner the Decipher genomic classifier. This is the 22-gene Decipher score that we should all be familiar with. It's the score that we get when we order the Decipher test on our patients, and it's on the clinical report. Below the Decipher score, you'll see signatures indicating the risk of upgrading or upstaging. For the Decipher prostate radical prostatectomy GRID reports, both will be grayed out, as they apply obviously to biopsy reports only. We should note that the risk of upgrading is based on the molecular model that predicts the presence of Gleason grade group 3 to 5 disease at radical prostatectomy. So if the biopsy sample already contains higher grade disease, grade group 3, which is 4 plus 3 equals 7 or above, the risk of upgrading will also be grayed out. Below is the risk of upstaging, which is based on the molecular signature that predicts the presence of seminal vesicle invasion, that's pathologic T3B disease, at prostatectomy. On the right half of the page are the tumor biology signatures that are highly relevant to prostate cancer. As we know, prostate cancer is very dependent on androgen receptor signaling activity. But there's always a question on how androgen-driven is a tumor. This signature looks at the level of androgen receptor activity in the tumor and signifies it as either being higher or lower. The interpretation language here as higher or lower is derived from an analysis that Decipher and Veracyte performed with investigators from the phase 3 randomized Titan trial. The next signature is cell cycle progression or tumor cell proliferation. And the result is also conveyed as either lower or higher. A higher result indicates more proliferative tumor biology. On the Decipher prostate radical prostatectomy GRID reports, the postoperative radiotherapy response signature, known as PORTOS, will also be shown. Because PORTOS was developed in the postoperative setting, it is grayed out on GRID reports that come from biopsy specimens. Higher PORTOS scores show an improved outcome when postoperative radiation therapy is employed. The next signature provides insight as to whether the tumor biology is more consistent with adenocarcinoma or if the tumor is more neuroendocrine-like. Tumors with neuroendocrine-like biology tend to be more aggressive and are associated with poorer outcomes. At the bottom, you'll find two molecular subtyping models. The first one on the left is one that you may be familiar with and was developed first. It was called PAM50. The PAM50 model was first established in breast cancer and identified tumors as having either a luminal A, luminal B, or basal molecular subtype. In the context of the GRID, this same model has been applied to prostate cancer using the Decipher transcriptomic platform. You'll also find the Decipher molecular subtyping classifier. That's a more refined prostate cancer specific version of the PAM50, and it reports the molecular subtypes as either luminal differentiated, luminal proliferating, basal immune, or basal neuroendocrine-like. The interpretation language, again, is specific to the subtype of prostate cancer itself. Both of these subtyping models have been studied in the context of various prostate cancer studies. In post hoc analysis of clinical trials, it's been shown that luminal tumors tend to have more androgen receptor activity, and they respond well to anti-androgen therapy. Luminal B or luminal proliferating tumors are more likely to have higher levels of tumor cell proliferation. Luminal A or luminal differentiated tumors typically have more favorable prognosis. And of note, this is the most common subtype among low-risk prostate cancers. Looking at whether a tumor is luminal A or luminal B, for example, might help us in future studies regarding active surveillance. Basal tumors typically have lower levels of androgen receptor activity. Basal immune tumors have demonstrated higher levels of activated immune cells. Basal neuroendocrine-like tumors have shown to have higher levels of stem cell and neuronal gene expression. It's important to note that these statements are generalizations based on tumor molecular biology subtype. On page 2 of the GRID report, you'll find the clinical genomic risk section. This section differs between the GRID biopsy and GRID radical prostatectomy versions of the report. Significant validation of the Decipher prostate test has shown that the Decipher score provides independent prognostic information about the tumor that's not always evident through an assessment of the clinical and histological features of the tumor. And for many of us that use Decipher prostate routinely in our clinical practices, we understand how to incorporate the Decipher score information into our patient care and how it may modulate the risk for our patients. However, it is nice to synthesize both the genomic data and the clinical pathological data. And so in a clinical genomic risk model, which is included on the biopsy GRID report, and the pathologic genomic risk model on the RARP report, we can synthesize these things together. I'll begin by describing the biopsy-based clinical genomic risk model that was published by Spratt and colleagues in 2018. This model essentially puts the Decipher score into the clinical context of each patient with prostate cancer. As per this model, numeric values corresponding to the National Comprehensive Cancer Network clinical risk group and the Decipher risk group are added together to give a total number or risk count that is the clinical genomic risk and displayed in the last column. For example, this patient has NCCN favorable intermediate risk prostate cancer and a high Decipher genomic score. The NCCN favorable risk cancer gives them 1 point, and the Decipher high risk category gives them 2 points. So the clinical genomic risk is 3 points in total. And this patient actually behaved more like a patient who is NCCN unfavorable intermediate risk. To put this in context, this patient's risk would be similar to a patient with NCCN unfavorable intermediate risk with a Decipher intermediate risk score. They would also have a sum of 3 points, or one that is NCCN high risk and a Decipher low risk score, also having a sum of 3 points. It's a nice way to think about the overall risk of the patient and where they fall on the spectrum of patients that have either similar genomic risk or similar clinical pathologic risk. On the radical prostatectomy report, you'll find the pathologic genomic risk model that's similar in concept to the clinical genomic risk model, but now it's based off of different clinical pathologic inputs and different data and studies that establish the importance of these factors in the model. Primarily, this model is based on a publication from Dallela et al. In 2017 in the Journal of Clinical Oncology. And it gives us valuable guidance in terms of the timing of post-prostatectomy radiation therapy. As many of you may be familiar, the randomized controlled trials of radicals, raves, and GATUG suggested that there's no significant difference between early salvage radiation, that's radiation defined as happening with PSAs at around 0.2 nanograms per mil, or adjuvant radiation, defined as having radiation at PSAs less than 0.2 nanograms per mil, among men that have Gleason grade group 3 disease or less, have extraprostatic extension, or a positive surgical margin. Now, what's not shown in this study is what do we do with patients that have a higher pathological or clinical risk? Those with seminal vesicle involvement, those with higher Gleason grade group, those with multiple adverse features. In the Dallela study published in the JCO, there was a multi-institutional effort to look at what factors could identify men that had higher benefit of early salvage radiation. This is basically men that would have benefit from radiation before their PSA would reach 0.2. And 4 risk factors were established: high Gleason grade group of 4 or 5, seminal vesicle invasion, lymph node invasion, or high Decipher risk, meaning Deciphers of 0.6 and above. Each of these factors has 1 point associated with it. If there's more than one feature or more than 1 point, this signifies that the tumor may benefit from earlier radiation at PSA levels that are lower than 0.2. To bring this to a point, in the Dallela paper, the number needed to treat if you had more than 1 risk factor, so a score of 2 or more, was 3 men getting radiation to prevent 1 metastasis at 10 years. So for an example, if a tumor was Gleason grade group 4 or 5, and then Decipher high risk, say 0.7, the risk count would be 2, signifying that that gentleman may benefit from receiving radiation therapy before their PSA reaches the level of 0.2 in the postoperative setting. A similar example would be a patient with Gleason grade group 3 disease and seminal vesicle invasion. Seminal vesicle invasion is giving them 1 point, and say their Decipher is high risk, that would give them another point. And this patient would then have 2 risk factors, 2 points, and would again benefit from salvage radiation before the PSA reaches 0.2. On the other hand, if you had a tumor that was Gleason grade group 4 or 5, that's 1 point, but a low Decipher score, say a Decipher of 0.4, and no seminal vesicle invasion, that person would have a pathologic genomic risk count of 1, only 1 point, and would not be expected to have benefit from radiation therapy until the PSA reached around 0.2. On the bottom of page 2, there are various published gene expression-based prognostic signatures for prostate cancer that have been recalibrated to a metastasis-free survival endpoint. The most validated among these signatures is the Decipher genomic risk classifier, and for that reason, it's demonstrated at the top. But there's other prognostic signatures have been developed, and they're shown below the Decipher genomic classifier. And where the gentleman is in their percentile rank of that signature is demonstrated. That rank is determined by where they fall in this cohort of over 100,000 cases in the GRID database. Most of the time, these genomic prognostic signatures track together. And the purpose of this figure is to give more of a context of where the tumor lies with respect to other prognostic models in the published data. Sometimes, in the case where the Decipher score is surprising relative to the clinical presentation of a tumor, let's say a high Decipher risk in an otherwise low-grade tumor, it may be useful to see where the group of gene-based prognostic scores are tracking in terms of risk. On page 3 of the GRID report, you'll find the Genomic Atlas. Now, the Decipher GRID looks at multiple genomic signatures across many different biological pathways. But in general, for prostate cancer, the hallmarks of these genomic pathways fall into 6 different categories. Are the tumors DNA damage repair proficient or deficient? Is a tumor more proliferative or less proliferative? Does it look more like an adenocarcinoma or is it more like a neuroendocrine tumor? What does the immune environment look like? Is it a more activated or suppressed immune environment? What are the other characteristics of the tumor microenvironment? What the Genomic Atlas is doing is tell you how this tumor compares to the other 100,000 plus tumors within the GRID data, and asks, is this cancer being driven more or less by one or many of these pathways? Where is there more genomic and biologic enrichment, and where is there a decreased enrichment? So what you can see on the plot in the middle is that the graph gets pulled towards pathways that are enriched, and then you can see the individual markers of those enriched pathways on the x-axis and where the percentile rank is in that axis for that pathway. And by looking at this, you can get an idea of the quote-unquote biological drivers of the tumor. And looking at the data in this way allows us to synthesize the compendium of data all together and make predictions about potential response to therapy that are more nuanced than just looking at what genes are mutated, what's overexpressed, or what's underexpressed at the individual gene or even pathway level. On the 4th page of the GRID report, you'll find the individual gene expression scores. Some of these genes may be important to you. For example, PTEN loss has been described in prostate cancer as being associated with aggressive disease. Regardless, in this part of the report, you'll see the gene or gene signature and the tumor score for that gene. This defines where does the gene expression in this patient's tumor fall in the rank compared to the other 100,000 plus tumors in the GRID report. Finally, you'll see, is the gene expression or signature considered an outlier compared to other men's prostate cancers in the GRID? For example, I mentioned PTEN loss. So the status may be that it's positive or intact, and that would be shown as blue if it's an outlier status. In other words, if the positivity is more than others. If it's PTEN loss, meaning PTEN is not intact, that would be negative. And if it's an outlier, so very much negative, it'll be represented in red. Note that the pathways on this page are organized in a similar manner to the Genomic Atlas shown on page 3. On page 5 of the GRID report, you'll find the expression matrix or heat map. This helps put the biological pathways and individual genes from those pathways in the context of the Decipher molecular subtypes, the models we were talking about on page 1. On the x-axis, you see the different subtypes of prostate cancer. These again are luminal differentiated, luminal proliferating, basal immune, and basal neuroendocrine-like subtypes. On the left side, as we talked about previously, are the hallmarks of prostate cancer or the different biological groups. Is this tumor more androgen-driven? What is their androgen receptor activity? Is it more or less proliferative? What does the tumor microenvironment look like, particularly in regards to the immune system? Is it an immune suppressed environment or immune activated environment? And finally, is this tumor more basal or more luminal-like? On the right side of the y-axis, you can see the individual pathways and signatures that are included in the groups that we mentioned that are on the left side. This heat map is looking at over 100,000 individual tumor expression profiles and how they parse out over the different molecular subtypes and biological drivers of tumors. On the heat map, red indicates higher activity, white indicates lower activity. For the patient's particular tumor that we're seeing here, we identify it as an arrow on the bottom of the page. The two black vertical bars represent the 3,000 tumors that are most similar to this patient's tumor. So in this example, the tumor is basal immune, has lower androgen receptor activity, that's demonstrated by it being more white, and higher proliferation, demonstrated on the heat map by it being more red. On page 6, the GRID report highlights clinical trials that include Decipher and that may be relevant to this patient. The listing of these trials is placed here because they may be an option for the patient. And the goal of this page is simply to share details of those studies and provide links to those respective trials on the clinicaltrials.gov pages. Finally, on page 7, you will first see a more in-depth description of some of the models that we designated on page 1. In the middle of the page, there are 3 tables that reflect the references that make up the genomic atlas, gene expression, and grid expression matrix pages. Finally, at the bottom of the page, you'll find all of the references used throughout the Decipher GRID signatures listed in alphabetical order. I hope you found this review of the GRID report helpful. There's a lot of data contained within the GRID report, and to me, that's a great thing. I want to remind you that the Decipher GRID and GRID report is still research use only. That said, there's been an ongoing commitment to research by the Veracyte and Decipher team, and obviously by investigators like yourself. And through those collaborations and through studying these different GRID signatures in clinical trials and other scientific settings, we're getting closer and closer to being able to use these GRID signatures in our practices. And that will allow us for more individualized precision care of our patients and thus better outcomes for these men with prostate cancer. Thanks again so much for your attention.